Ladies and gentlemen, we're moving into the next session, which will be the health section. We'll be talking generally about health as regards the continent, Africa. Joining us online, I would want to recognize, the National Coordinator, Presidential Taskforce on COVID-19 Nigeria, in person, Dr. Sani Aliyu. He's also a qualified and certified microbiologist and infectious diseases specialist. He's also the former Director General at National Agency for Control of AIDS, NACA, to mention a few of his qualifications. Also to join us online, Dr. Elliot Koranteng, Tannor, a consultant nephrologist, Komfo Anokye Teaching Hospital, Kumasi, Ghana. He is also a fellow of the West African College of Physicians and also a fellow of the International Society of Nephrology, to mention a few of his offers. Also to join us as a speaker is the CEO, Helium Health, who happens to be the co-founder and chief executive officer of Helium Health. And Helium Health is the largest electronic medical records provider in West Africa. He is also the founding board member at King's Chat. He is a former technology analyst at eBay, PayPal, and Goldman Sachs. I'm talking about no other person than Adegoke Olubisi, who is ably represented by the head of Public Sector Regional Growth, Helium Health, in person, Tolagbe Martins. And to help us champion this discourse, I would want to also invite online the CEO, EpiAFRIC, and Director of Policy and Advocacy at Nigeria Health Watch, in person of Dr. Ifeanyi Nsofor. Over to you, Dr. Ifeanyi Nsofor.
Thank you so much, Moses. Thank you for such an intro. Again, thanks to the panelists, Dr. Elliot, Dr. Sani, as well as Tolagbe Martins, for making our time to be part of this meeting today. Let me just say quickly that as much as possible, we should be very brief with our responses. For each question, I expect that each panelist should spend not more than 2 minutes to respond, so that we can take all the questions that we have and make sure that we have a very robust engagement this evening. So I'm going to start with Dr. Aliyu. And this question applies to all the panelists, but Dr. Aliyu first, then Tolagbe, before Dr. Elliot. So Dr. Aliyu, I mean, COVID-19 has devastated, lives, economies, and businesses. And again, I think your role as the national coordinator of the Presidential Taskforce on COVID-19 is quite strategic. What 2 lessons are you going to share? One positive and negative as far as Nigeria's response to COVID-19 goes. Dr. Aliyu, you may have to mute your mic. Sorry, Dr. Aliyu, your mic is on mute. Dr. Aliyu, your mic is still on mute. Okay, it's on mute now. So I think his network is kind of.
Can you hear me now?
Not really. No, we can hear you, Dr. Aliyu. So, Dr. Aliyu, can I just jump to Tolagbe? Why, maybe your network, improves. Okay, so Tolagbe, from the work you guys do at Helium Health, I know that you support 2 lessons under 2 minutes, one positive and one negative that you're going to share with us.
Okay, so 2, I think the first lesson is the importance of preparedness. The truth is, Nigeria was really able to step into its Ebola pandemic response. Having that there as a foundation meant that there was something to step into and adapt and repurpose to this. I mean, so we went from something, to this, but having that framework in place is a very, very vital aspect. So I think that's probably a positive. On the negative side, I think it's just the lack of a safety net overall, which sort of is a characteristic of our healthcare system here, meaning that some of the most vulnerable sectors of the population, despite the best efforts, have been, irredeemably and irretrievably affected by this pandemic.
Okay. All right, thank you so much. Preparedness as well as our lack of social safety nets. Dr. Elliot, I know you do very great work in Ghana in kidney health, advocacy, as well as a clinician treating people with kidney disease. And this is a risk factor for COVID-19, increases the risk for people having severe forms of the disease. 2 lessons from you, from your work in Ghana, positive and negative as far as COVID-19 response is concerned.
All right, so thank you very much, and thanks for having me once again. So quickly, I think for the positive, I must commend the country and the presidency for how they managed the situation. Indeed, probably I'll swerve straight into the negative to mention that probably was a bit late, let's say 2 weeks into being late, but some way, somehow, when they decided to be pragmatic, it was phenomenal. And indeed, I am also actually on a committee that discusses COVID amongst, of course, nephrologists across Africa, and they were actually excited about how proactive our government was, one, trying to marry the danger of COVID with, of course, the socioeconomic situations that came with the lockdown. So actually, we're one of the countries that were able to lift the lockdown quite early when things were not so clear. And it's actually because they had to weigh. And I think that is actually one positive thing, that in the light of a pandemic, you still may have to consider, the socioeconomic impact of the disease. And of course, the fact that COVID, one way or the other, in terms of numbers, were not too great. And like I said, as of the time where we're not too sure, he took a bold decision. I think that is, for me, one positive thing that we have learned. Again, I think I've mentioned a bit about the negative, that, well, could we have, closed our borders, a bit earlier, or waited for us to get our few cases before closing our borders. I think some other countries, Rwanda and all, were, straight to the point, closed it quickly to be able to mitigate the effect. So I think on my part, that actually is the negative here.
Okay. Thank you so much, Dr. Elliot. So what I hear you say is, one, there was very strong political will by the government of Ghana. But again, you're not sure that that political will actually came into play as far as, closing the border. And I think that one is really, open for argument, because to a large extent, countries work based on science and data that they get before they take decisions. So back to Dr. Aliyu. Sir, I don't know can you talk now?
So yes, can you hear me now?
Yes, I can.
Perfect.
Okay, so apologies. I'm afraid my internet is very unstable. I'm in an office building that has always had fairly unstable internet service. But unfortunately, because we are having the PTF press briefing this afternoon, I just have to be here. So thank you for inviting me. I've heard the 2 questions. I've also heard the responses. I think mine will be slightly different. In terms of the key lesson that we have learned from the PTF side, it's really the advantage of working with partners. The COVID response has been very different to other pandemic responses we've had in the past. The engagement of the private sector has been huge. I'm not sure people are aware, but if not for COVID, I don't think we would have opened up our airports the way we did. The availability of the portal, the availability of IT services, etc., has been huge. But we've also learned lessons. And a key lesson to me really is the need for us to engage communities very early on, particularly religious leaders, traditional rulers, opinion leaders, etc. And you can see that from our risk communication and community engagement activities. We started things fairly late from that perspective. We took a very sort of medical approach. Here we go. This is what we need to do from the health side, and actually ignored the fact that people are less likely to listen to us and more likely to listen to their local authorities and leaders. And if I was to do anything different, we're not hoping for another COVID pandemic, but it will really be to start upfront by starting to inform people of what COVID is about and the need for them to engage and cooperate with us when it comes to non-pharmaceutical interventions. I've heard the comment about closing airports early. To be honest, I don't think it would have made any difference, because virtually every country in the world, other than the small islands, have COVID. And I remember when we closed our airports, we had a large influx of positive COVID persons through our land borders. I think it was through Ogun State. So I don't think closing the airports any earlier would have made any difference at all. But so that's really my two answers. And I hope the internet continues to be stable so that we can continue to engage. Thank you.
Okay, thank you so much, Dr. Aliyu. And I'm happy you mentioned COVID and the private sector involvement. That's one of the questions that we have here. But I want to quickly, I want you to quickly talk about, because as far as infectious disease outbreaks are concerned, it's no longer a question of if it will happen. It's a question of when. So again, if we look back at lessons learned from COVID-19 in Nigeria's response, what two things do you think we're going to do differently? You mentioned the community engagement, which is one. What other thing do you think we should do differently to prepare for the next pandemic?
I think in terms of diagnostic capacity, it's really important that we maintain what we have currently developed. NCDC now have a network of laboratories across virtually all states. We have over 61 public health laboratories belonging to government, state governments in particular, and also about 20 private laboratories. We really need to make sure that the investment that's currently going into these molecular laboratories is sustained. And we need to expand beyond just molecular diagnostic capacity to include other microbiology services such as blood culture systems, serological systems, etc. And also improving on the electronic side in terms of IT infrastructure that is linked to pandemics and emergency reporting. We clearly were caught napping this time around. We've just been lucky as a country. You can see what's happening in India and other parts of the world, the number of deaths that they've been having. But I think Nigeria really has been very lucky. In fact, Africa in general has had a relatively mild epidemic, but maybe this may not be the same if the next pandemic like influenza comes in, for instance. So to me, it's an opportunity to reset our health system, but in particular, making sure that health preparedness is really up to scratch.
Okay, thank you, Dr. Aliyu. So Tolagbe, what would you do? What two things will you do differently to prepare for the next pandemic?
I mean, so we've actually done quite a lot of work in this space presently. We've supported Lagos State, for example, with its emergency response systems. And so everything Dr. Aliyu has said about the importance of keeping that network in place, being able to properly monitor and evaluate what's going on so that we're better positioned to actually be able to track and trace, is so critical. So our function as, Africa's leading healthcare tech company is to continue to work so that we are spreading this gospel of how technology actually makes life easier for people like Dr. Aliyu, makes life easier for, a doctor in a remote part of the country who has seen something that he has read about or Googled and is looking, because, we all remember one of the key cases was actually a doctor in Ogun State who picked up on the symptoms and, did her research and flagged it. So having the information available, having the database to check against, being able to use technology is, you can't really expect me to say anything else.
Okay, I hear you. I hear you. So, yeah, and you're absolutely right. Data is key. And without data, we'll probably all be in the dark about what it is that we're doing. So I'll just move to, if you don't mind, move to Elliot.
Of course not.
Okay, thank you so much. So Dr. Elliot, what two things will you do differently going for the next pandemic?
Yeah, so riding on what has already been said, but I think I'll just bring in this little tweak in the sense that, well, we have infectious disease on the panel, and indeed it's COVID, and there's a lot of attention. But I think one of the things personally I worry about so far as in terms of the non-communicable disease is the fact that when it is communicable, yes, the whole world shuts down. but we realize that one of the major risk factors are non-communicable diseases as per causes of death, okay? So I think that generally, it's actually one thing that we should be looking at, that yes, COVID will come, probably another bigger one will come, but who is more at risk, of getting these? And we need to be able to ensure that we are well prepared in that wise, that even if it comes, our mortalities will be this good. I think if we compare our mortalities to elsewhere, I think our advantage is that, well, we are younger, they are older and stuff like that. So probably these are some of the things. Maybe Dr. Aliyu can mention more, but I think the diabetes, the hypertension, the heart diseases, the kidney diseases are actually the killers. And indeed, for some of us, we're actually not sure whether the people die with COVID or they die from COVID. I mean, from our point of view, so I think these are some of the things that we need to critically look at. So the non-communicable disease part of things. And then again, the systems that we've put in place, Ebola came, we were prepared as a country in Ghana. We're lucky we never had Ebola. So it looks like we couldn't try our systems one way or the other. So this one took us a bit off guard one way. So my thinking is that these systems that now we have put in place, we shouldn't just shut them off. We should be ready, keep them in readiness, probably try ourselves just in case it happens. What are we supposed to do so as to mitigate the next pandemic? Yeah.
Okay. Okay, awesome. So in other words, we don't want to hear people saying it's not our portion, epidemics will not happen. They will happen. We don't want to hear stories like that. Elliot, I'm happy you talked about non-communicable diseases and the fact that people are dealing with all sorts of, other diseases apart from communicable diseases on the continent. And I think this is a nice segue into the next question on universal health coverage. Because I think if you look at the universal health coverage as WHO defines it, it's a spectrum of care. You have the preventive, you have the curative, you have the palliative, you have all sorts of, So, and if you look at out-of-pocket expenditure on the continent, Nigeria is about 77% out-of-pocket expenditure. Ghana is about 40%. So what one way, Elliot, do you think Ghana, and of course, by extension, the continent can gradually move towards universal health coverage?
All right, so thank you very much. So indeed, you've given out the statistics, so probably we don't need to mention it. But I think when you look at the numbers and the numbers are that bad, then you'd want to look at other neighbors who have good numbers. And you want to ask yourself, what are they getting right? All right, so we'll not go far. Indeed, Ghana, of course, as compared to Nigeria, we are much better so far as our insurance
let's
is
not
concerned.
Get into that jollof quarter now. Well, go ahead.
I know now. In fact, you are now bringing yourself now, so I'll hold it right there. But generally, I think from 2000, indeed, we had a government coming in who was peculiarly interested in ensuring that everybody gets affordable healthcare. And indeed, they brought in the National Health Insurance Scheme, and the coverage was amazing. Of course, over the years, things have not been the way we expected to be, but of course, that's on the political front. But I think generally, I would not even compare ourselves as Ghana as the yardstick. I think we need to look at those who have done 11%, and we are talking about Rwanda here. I mean, it's amazing that people can do. In fact, Rwanda is actually less than 10%, I should say. And it's what? It's leadership, So if you have a good leader who decides this is how we want to go about it, and they try to hit it hard, I think that helps. But what has made Rwanda, I mean, you and I, Ifeanyi, were in Rwanda where we try to learn their systems, and it's all about, community-based, so some of these, how to collect the money is not at a high level of sitting in Abuja or Accra or whatever it is like, but then you are going down to the community, and which people are the ones who are going to be affected and cannot even afford the basic premiums. These are the poor ones. So what are they doing? They're actually supporting people to pay premiums, and indeed very low, should I say, percentages in terms of what they are supposed to. So about 4%. And what actually they realize is that most people are able to pay off their premium and be able to pay back even before time. So you get the people involved in their own healthcare.
Okay.
In fact, I've read in places where it is said that whether you like it or not, it's the citizenry that would pay for the health service. Either they pay properly in terms of preparedness, in terms of ahead of time, or out of pocket when they need it. So we have to decide to at least share the risk, pull it together, share the risk, so we all pay something small, that at the end of the day, whatever your condition is, you'll be able to take care of yourself. So I think leadership is key, and the fact that we have to go back into not this.
Okay.
Qualities are great.
Yeah. Okay.
Sorry.
Okay, thank you so much. Thank you, Elliot. Dr. Ali will soon leave. So, Dr. Ali, if you can just respond to this question about, what one thing we can do to move Nigerians towards universal health coverage before you leave.
So thank you, Ifeanyi. So what is it that we lack really within our health system? I think the main problem in terms of our healthcare system is the issue of access to healthcare, i.e. availability. And as you mentioned, the out-of-pocket payment really in Africa is very high. We also lack sufficient equipment and supplies. We lack a good IT systems. We lack a good logistics. And all these require increased funding. But where do we get the funding? In my view, we need to continue to push for the Abuja Declaration to be respected by all African countries, including ourselves, where at least 15% really should go towards health. And I think we are pushing against an open door now that we have, now that the COVID pandemic has come and gone, well, hopefully going soon. And it's very clear to our leaders, to governments, etc., that you cannot continue to ignore health. Spending on infrastructure is a good thing, but infrastructure in the context of a sick population really doesn't make sense. So that expectation really should be there from the public, and also working with our politicians, our political leaders, our national assemblies, and also the private sector. We shouldn't forget that the private sector continues to be very critical when it comes to increased funding for the health system. From the Nigeria side, the NHIS needs to really reform. I'm pleased that they are already making the right noise, and I think there's an act, a modification of the current act that's currently going through the National Assembly, and we look forward to that. A situation where only 1 to 2% of our population is covered is really not good enough. There needs to be a system that would allow the common man to be able to access decent healthcare when they are sick, for the very poor, and for the very rich that continue to escape out of the country to access healthcare. They've seen what COVID can do, because even with your money during the COVID pandemic, a lot of countries were closed. Airports were no longer functional, and people had to rely on what was available in country. So this is the opportunity. Let's work together, both from the public and the private sector side and the donor community, and make sure we continue to push for increased funding. It's the only way we can sort out the issue of out-of-pocket expenses. But thank you, Ifeanyi, for inviting me to this. I have to apologize. Our press briefing is just about to start now, and I will need to join them.
Thank you so much. Thank you so much, Dr. Aliyu, and thank you for your service to the country. For the past 7 months, you guys have been doing this almost on a daily basis. So thank you. We appreciate and we thank you for your service.
Thank you.
Okay.
Thank you very much.
All right. So Tolagbe, over to you. How do we get universal health coverage across the continent? But again, you can use any examples of the work you guys are already doing.
I think critically, just to echo something that Dr. Aliyu said before he had to go, is the issue of partnerships and making sure that the public sector and the private sector are working hand in hand. It's quite clear that it can't be done by anyone. There is no magic wand that's going to fix this problem. What we're going to have to rely on will be the partnerships at the end of the day. So like we had said, for example, where you are bringing in, what I always find, or any successful PPP, public-private partnership, is just leveraging on the access, allowing the public sector to provide what we have, what has become, a bit of a hackneyed phrase, but an enabling environment, so that the advances and the lessons and the learnings from the people that can pay can be passed on to the people that can't pay. That's always what's going to happen. And even when we talk about, and Dr. Liu mentioned, donor partners and international funding, looking at the lessons that you've picked up, what worked somewhere, how can we best apply it in a targeted and cost-efficient way? And that's why obviously having a national data information exchange would be so important, because then what we did, we tried it in Asaba, we're going to go and replicate it in a community in Adamawa, for example, and that's where that particular synergies will come. That's where they'll come from. The right balance between the public sector who can be nimble, who don't have to, do everything by committee. And yet that consensus building approach that the public sector brings is also very critical, so that everybody is carried along, which is, very, very important. And just to echo something that Dr. Aliyu had said again, which is using the community leaders to drive some of these particular reforms so that it becomes part of our culture. We have, for example, we have, this co-ops, and we do this for big projects. Everybody joins what we call AJO or, ASUSU, for example. And so trying to sort of maybe draw those particular traditional lessons and apply them to healthcare and benefits. So it's not, God will not let it happen, or it will not be our It's going to be everybody, really.
Okay. All right.
That's good to get this done.
Okay. Great. So, interestingly, if you look at the data, in Nigeria for health financing, the last national health accounts that was done, total health expenditure in Nigeria was about $10 billion a year. $7.7 billion was out of pocket. And the way I try to look at that is that this is money that people spend to get substandard healthcare. Just about $1.1 billion of that is donor money. $1.3 billion is all the governments, federal, state, and local governments combined. So the money that Nigerians spend out of pocket is 7 times what the donors give us. So that I think it's really time for us to begin to rechannel. How do we rechannel the existing financing within the system towards health insurance? And like you said, people paying based on their ability to pay, or, we can define all that. But anytime I look at that data, what it tells me is that we have the solutions to our problems within the country.
But I think, without wanting to talk over Dr. Elliot, I think the critical thing about what you just said about out-of-pocket expenses is the challenge with out-of-pocket expenses, of course, is that they're not planned for. So as a private entity, I cannot guarantee that I cannot project based on out of pocket. I don't know what's coming because it's always, almost like an emergency situation. So to buttress your point, if even half of that was planned and properly funded through insurance or some, those kinds of schemes, then even the private sector would be better positioned to offer, a wider pool of services just because they know that they're going to get the income.
Yeah, absolutely. So, Elliot, let's talk a bit about the private sector and the kind of support they've given. For Nigeria, Dr. Aliyu had already spoken about it. The Private Sector Coalition for COVID-19, otherwise known as CACOVID, was quite instrumental, is instrumental to the response to COVID-19 in Nigeria. What is your experience like in Ghana with the private sector supporting COVID-19 specifically?
Oh, obviously, I'm not sure our economy will be surviving if it's the government who is supporting COVID, because like Tolagbe just mentioned, generally, we didn't plan for COVID. I'm not sure anybody, as of their budget planning for 2020, thought that COVID was going to happen, for which, okay, let's put X amount of money aside for it. But definitely, we ran into trouble, and indeed, the private sector has been phenomenal. In fact, they came in terms of big, huge companies supporting. But we used to make noise from the clinical point of view because we're not getting PPEs to use. In my hospital, for instance, those who came to the rescue before government organized themselves was the private sector. Apart from the ones that they actually pulled towards government to now distribute to us, which indeed, sometimes actually they realize that if it goes to the ministry before it gets to us, unfortunately, it doesn't get to us. So most of these private people would have to now come to us and give us the PPEs, so definitely we cannot run away from the private sector and how helpful they've been in this fight of COVID-19. Yeah.
Okay, awesome. Tolagbe, I love Helium Health. The work we do at EpiAFRIC, we have our health meets tech agenda where we, get both communities, health and tech, to begin to look at how to solve our problems in the health space. And I think that Helium Health is doing an awesome job already in Nigeria. Talk to us a bit about what you guys do and how you're improving the health space.
So we are, this is the bottom line, right? There's this joke about, well, how do you decide to eat an elephant? Do you eat it from the trunk or do you eat it from the tail? And everybody says you just have to eat it piece by piece. And so we've come in with quite a sort of surgical approach, which is our focus is on health technology, and we look at it from a number of perspectives. You put yourself in the shoes of a patient and say, how can technology help to connect you to the best doctor for your case? We, at the end of the day, in Nigeria, we still have 4 doctors to 10,000 patients. So really and truly, how can you as a patient have access to the best possible care? Technology can support that. But it doesn't end with the patient, does it? It also, the providers, the administrators, they also need technology to look at, this is my limited budget, how best can I deploy it? How can it have the best possible outcomes and the widest possible reach? Again, technology can support that, whether it's through telemedicine, whether it's through just having, all your information pulled in one place, able to generate the right kind of reports that will be meaningful to, this intervention worked here, but it didn't work here. We noticed this. How many of our infant patients, for example, are sleeping under treated nets? Key information that is vital to improving the outcomes overall. That's what we're able to give the tools to. And finally, better decision making, better policies overall. We're talking now, there are so many lessons, for example, from just from COVID as a global phenomenon. What are the learnings? What are the lessons? It's technology that's going to go through all those and give you the information that will drive what we're saying now. It's somebody calculated how much was being spent to give us these figures. And so where we see ourselves is allowing people to make better decisions, allowing people to be more effective so that the actual clinical work or administrative work can be done. So much time, effort, resources are lost in drudgery or just moving one file from one place to another. We've even seen how technology has impacted, globally work. We joke about it now. You realize maybe you don't need to work 5 days a week. Maybe you can work 3 because all the time spent, so we're seeing what the import and impact of technology will be. And so we are very excited because COVID has been an opportunity in a way, because it's made people recognize just why you need everything in the cloud, whether it's raining or not, why you need your information, at the touch of a button. What happens if your patients can't come to you? Can you go to them? So when rain, life gives you lemons, you make that lemonade. We are finding we don't quite as much have to prove the necessity of technology. Instead, we can focus on ways in which we can help.
Okay, thank you so much.
Ifeanyi, just to write on what she just said with technology, I just want to mention that, in fact, there was a paper I read, and what we read, the paper said was that generally the out-of-pocket payment sometimes goes so huge because people are actually paying for services they don't need to pay for. All right. Absolutely. So generally, that like the triangle, the way it's supposed to be, the community should have a lot of hospitals, primary care, and all of that. And then, of course, the teaching hospitals sit at the top. But what do we see now? Unfortunately, somebody will just go with this viral infection that does not even need antibiotic and gets an MRI done, in the teaching hospital. All right. So indeed, when we have technology telling us how much the spending is, and we have a system that clearly lets you know where to go for with what condition, that helps. Having said that, of course, the private sector can be there. I can decide to pay for whatever I want, and then I go to that place and pay for. But if you are thinking about health coverage, I think the difficulty is that if we are not careful, then a lot of money now goes into ensuring the few are still getting, in fact, in my opinion, what they don't even need. And then the little resources that is left, is for the other people to work with. So I think that is actually one thing that we may need to look at as a continent, to avoid the waste, I think.
Yeah, awesome. Thank you so much, Elliot. And at this point in time, I just want to, say a bit about what WHO says about the primary healthcare system. WHO says 80 to 90% of the healthcare needs of an individual throughout the person's lifetime can be provided at the primary healthcare system.
Absolutely.
Yeah.
So what I want two of you to do, let's start with Tolagbe, because I want you to, this meeting is about the future of healthcare.
Yeah.
So I want you to tell us your dream for the future of healthcare across Africa. Tolagbe, you have 3 minutes for that.
Wow.
So go to town, just dream for us. Let's see.
Okay, so my dream, my dream, okay. So my dream is honestly seeing something that's the right synergy of public and private partnerships. And, I really mean it when I say that is critical. And why is that so important? It's because like when we talk about hospitality, we talk about accommodation, right? You want that to be a minimum standard, a gold standard of clinical care across the board, regardless of your ability to pay. The frills, the extras, and that's what we mean, the frills, the extras will be based on your capacity and your ability to pay. But can we be sure that you will be properly monitored, that your vitals will be properly checked, that you will get the right health advisory, the right tests, the appropriate interventions at the time. So whether that's as an infant, are you getting all the immunizations that you need to ensure that you are able to deal with life? As you mature, are you getting the right sexual and adolescent and, information? As you progress, are you getting the right interventions as a woman? Are you getting your mammogram information at the time? Are you getting your pap smears? Those kinds of critical baseline that just provide us with what I call, not necessarily but what, you look a good quality of life. Now, and we see this in countries where there is socialized medicine, because of course, if then I decide that I want to have, some interventions because I want to stay looking 35, which still fall within healthcare at the end of the day, those will be based on my ability to pay. And that's fair enough. But should I be having to crowdfund for life-saving, treatments? I think, I don't think so. So in my dream world, you would be able to access critical, relevant, dignifying healthcare, regardless of your ability and capacity to pay. So that may mean longer wait times. It may mean waiting for an appointment. You might not just be able to get something on the same day, but will you get it? And when you get it, will the clinician be experienced enough? That's very, very important. And I think that's, so, back to my very first point about having the safety net in place, and therefore, even a practitioner being able to charge some patients what they can afford to pay in order to be able to treat other patients who can't pay. And you see that system working in other places, so that a practitioner can still have a decent standard of living. It becomes a career worth of dignity, and that they can get on with their work and focus on their work. So my dream world sees practitioners being paid something that is dignifying, sees patients also having that dignity, and governments providing the safety net for everyone.
Yeah. Awesome. Thank you so much, Tolagbe. I think the key word here is dignity, and I think that's really spot on for everybody across board. Okay, Elliot, time to dream.
Time to dream. Yeah, time to dream. Let me go on. So my dream is to see that old lady in that village, or that young chap in that village, get access to that transplant done, or that's whatever expensive it is, just by the fact that, by the virtue of the fact that the system can at least take care of. Now, I think when we look at access, I think access has been mentioned. The idea that everybody thinks about coverage is all about access, but I think it's been mentioned clearly that access without quality becomes a problem. So you cannot erect a CHIPS compound somewhere where the people, even in the locality, feel there's no nurse who can actually take care of me. And indeed, that actually becomes the problem. So you have people now transporting themselves to the city because they cannot trust their own system in there. And it's an interplay. Of course, the health system is such a dynamic and very great thing that if there's a little problem one way or the other, health workforce, I mean, are there availability of medicines? Of course, I mean, so if you have the ability to pay, and we hear that all the time, doc, in fact, even with our insurance system, doc, you write whatever medication you want to write for me, I will go and buy, so co-payment now comes in because they actually feel that the quality of medicines they'll get under our so-called coverage of insurance probably might not be the best. That becomes a problem. So, and of course, quality in terms of how you'd want to define it is also actually another ball game altogether. And actually enjoy the quality of life. I'm actually an advocate for quality of life for whatever thing that you are doing. It's not enough to just sometimes increase people's longevity or survival. People are living long without quality of life. If they are living for a year with whatever condition and the quality of life is good, I think I'll prefer that. So I think marrying the access and now talking about, getting payment minus quality, I think we are missing it. So marrying the two becomes a bit more complicated. And of course, that's why we need to keep talking and trying to solve the problems.
Yeah, awesome. You talked about quality. Interestingly, the WHO DG, Dr. Tedros, says, he asked a question sometime in 2019, can health be anything but quality? Do you understand? Can health really be anything but quality? And which really tells you how quality should permeate every aspect of healthcare delivery. So the final thing I want us to talk about, Tolagbe, Elliot and I are senior fellows at the Atlantic Institute, and we visited Rwanda last year. And when we walked into the class, we saw a mural on the wall, and both of us took photos under the mural. And what the mural says is to achieve equity in healthcare, we must achieve equity in health education, which I think is so spot on, at the University of Global Health Equity. And because if you look at the core function of primary healthcare, to me, is a combination of health promotion as well as health prevention. Absolutely. How do we get that woman to know that she has to exclusively breastfeed? Because that alone can ensure that this child doesn't fall sick. So 2 minutes each. Again, I'm starting with Tolagbe. What are those ways you think we can really communicate health to our people, no matter where it is that they are based?
So you have to tailor your message to suit your community. And I think, that's the reality of it. But at the end of the day, you're also going to try to borrow from so define your success criteria. I think so many times we go into these things not fuzzy on the detail, right? Yeah. So how quickly do you want to get this messaging across? I was having a very interesting conversation with somebody that you may both know, and we were talking about how in 40 years, so much of our social and cultural mores have changed. He was speaking specifically about Nigeria, marriage, polygamy, and so on. And we had this conversation with a view to saying, what were the lessons? How did they change everybody in a 40-year span? And we want to know how they did that so that we can apply that to every other aspect, specifically health intervention. How do you carry out? And I think the church had something to do with that. Religion has something to do with that. Culture and peer pressure. Let's never, downplay the impact on imports of peer pressure. So tailoring the right messaging, meeting people at their level, and you can't get away from community-based interventions. I think, honestly, everywhere that we've seen empirical improvements, it's because the community have embraced the reform and championed it. So whether that's starting with school-age children, so that some of that messaging becomes, something that has become, you also want to look at interventions that have gone elsewhere. So recycling, waste management, proper disposal of waste is something that everyone has realized if you get the children to do it, they will go home and shame their parents. They will encourage them. So again, let's start at that point. because, you know, in 20 years time, something that you're introducing will become the norm. So, and, you know, but being able to track this is very critical. So being able to draw from best practices, look at who did what where and how successful was it, and how can we tailor that and adapt that to suit our unique situations. One size definitely doesn't suit all. And even in a country like Nigeria, which we know right now, we're living through the reality of so many different regions with different needs, well, the same challenges, but different needs, or having to meet them at the different points. So local expertise, best practice, community-based interventions as early as possible. That's what I would say, you know, for wellness prevention is vital.
Great, well said. Elliot. Elliot, can you hear me? Okay.
I think you are breaking. Oh.
Okay, so can you hear me now? Tolagbe, can you hear me? Let me be sure.
I can hear you perfectly.
Oh. Okay, Elliot, can you hear me now?
Okay. I can hear you now, but
okay.
You're frozen. But I can hear you now.
Okay, so what I wanted to talk about briefly is how do we, you know, really take the message to people, no matter where it is that they are based, about health promotion, health prevention, health seeking behaviors, and all.
Yeah, so thank you. And I think I love this question because you know what I do and what I love to do. And it's actually about education. I personally feel that is one area that as healthcare professionals, we've not done so well. I actually push my colleagues that we have all the knowledge and we sit in the teaching hospitals, we write big books, we bully medical students. But meanwhile, the woman across the street has no idea how they can prevent themselves by doing a few things so they don't get, you know, into being used as patients to be taught. I mean, if you understand what I'm saying. And then again, I also make a point that indeed, so far as we've blamed the system one or the other. So I look at the education as to education of the general public, and then of course, education of these primary health care providers. You know, so we sit at the pinnacle, we keep blaming them that, listen, you are not managing our malaria well, you are not managing the kidney disease well, and they are coming in with complications. The question is that, have I gone down to that district hospital? Have I gone down to that CHIPS compound to even educate that nurse to be able to teach the people around what I think is good information? Because we keep writing the research and coming up with the cutting edge, and we keep telling them they are giving archaic information. If you understand what I'm saying. And again, it is very, I mean, the more influence you get is to make sure that the people, so like we're saying, if we are looking generally at the community, if I go straight to the community, chances are that they will not listen to me. But if I go with the community health nurse, if I go with the community health care worker, who tells them in their language and who tells them the way they need that language to go down, they are more likely to listen to her than me. So the issue of health promotion goes beyond just the public. And indeed, what I've realized is that we are late. What already is being churned out there in terms of bad information that the people have accustomed to. If you listen to your normal radio station, they are talking about all sorts of medications that have, in fact, they are actually creating more harm than good. But one way or the other, that market woman who sits and sells her tomatoes thinks that that is the best information because she keeps hearing it every day. And indeed, sometimes in the clinic setting, they come to you and the way they present their symptoms, you can actually feel they are presenting it the way they've had, you know, these quack doctors sell their medication. And they are expecting you give them some medication that is similar to what that should solve the problem that, you know, it's a really crazy ball game. And that is why I never sit aloof in my teaching hospital, because I feel there's a lot of work to be done and it has to start from somewhere. And every health worker, I don't care what you know, but that little you know can help your church. That little you know can help your community. So we need to go out there and educate. If we are to let that 40-year thing that Martins mentioned happen, we need to get out there because it's happening in our clothing because people go out there to dress for them to see. If you want the health to change, we have to go and let them hear in their own language what we want to change. And of course, the hearing is one thing, the change is another. But if they don't hear, how are they going to change?
Exactly.
Absolutely. And if I may just throw in an Igbo proverb here, that your morning begins when you wake up. One of my favorite proverbs, because what it tells me is that it's never too late to do anything. Once I come to that realization, I run with it and make sure that that information is passed across. We just have 4 minutes, so just 1 minute each. Your parting words before we hand over to Moses. Let me start with Tolagbe.
Ladies first.
My parting words, it's funny, something that Dr. Elliot just said about being able to go down to the bottom, and that's really what we can help with. We are able to help with those kinds of things. Dr. Elliot could actually stay in his ivory tower and reach out to healthcare practitioners via Zoom, via WhatsApp, via any form of platform, giving this information in the bite-sized places. Because you see, at the end of the day, improving this information dissemination is vital. There's no doubt about it. And coming against misinformation, I think we've seen it on every aspect. Getting the right information out there is going to be arguably the biggest challenge, because we're combating, I hate to say it, but we're combating fake news in every aspect.
Absolutely.
And this one is literally a matter of life and death. So, getting the right information, using the right tools to get the information to where it needs to be. And that's our mission. And that's why we're here at the end of the day.
All right. Thank you. Elliot, 1 minute. Parting words. We're back to the
thank you. My parting words, I think, I mean, health is wealth, basically, and without health, like you would say, we are actually nothing. And indeed, we need to, again, champion the health wherever we find ourselves, one way or the other. We need that politician to know how important it is. And indeed, I think from the earlier part of the discussion, we had a fantastic Abuja declaration, 15%, everybody agreed. But what are we doing? Everybody is doing mostly less than 10%. And the point is that we are not holding our leaders accountable. I think if the building blocks will work, it's all about leadership. If the leadership is strong enough, then that is when some of these things will work. Yes, other sectors are important, defense, agric, and all of that stuff. But we need to let them know how important health is. I mean, and fora like this are actually helpful to drum home the point that at least we need to. Because if we don't have health, we have nothing. And I'm quoting you.
Absolutely. I will not charge you for that, Elliot, for quoting me. And I'm also going to end with it. That was the title of my TEDx talk, TEDx Ogwiro talk of 2018, that without health, we have nothing. Thank you so much, Tolagbe, for making our time. Elliot, thank you. I wish you had time to talk about jollof rice, but we don't want Nancy to beat that on our neck.
Oh, that one is a done deal already, so we don't need to talk about it. Don't worry.
All right. Thank you so much, guys. And Moses, over to you.
All right. Thank you so much, Ifeanyi Nsofor, the CEO of EpiAFRIC. And